Good afternoon, friends. It's really a privilege that we all are here, and this is a very current topic that there was practically 20 years back we had TURP and nothing else, and in last 2 decades we have seen number of modalities which have come in the market, and they have to stand test of time. So that is something which is very important, and what we are looking from out of all these modalities today is that can we replace TURP? And if you go to the Campbell's urology, you will notice that Sir John Fitzpatrick writes it took at least 50 years for the TURP to be accepted as the established treatment, and it took even longer for its exact role in the therapeutic armamentarium to be found, but it is very likely that someday TURP will be replaced as the ideal interventional treatment for BPH. Now, this is the vision or imagination of a person of the magnitude of Sir John Fitzpatrick, that now the turbulence which is available today to all of us is witnessing this fact that someday TURP is likely to be replaced. Now comes the question that what we are looking for when we are looking for a replacement. And when we think of such a situation, whatever has been debated in last 2 decades, if we put them into a simple comparison, say on safety and efficacy module, because whenever we deal with a benign disease, our goal is that the treatment should be lifelong, treatment should be efficacious, treatment should be safe. And such a treatment means that if you put these bars, you will find that there are modalities which are safe but not efficacious, like you have prostatic stents, balloon dilatations, microwave thermotherapy, tuna, like that. There are modalities which are efficacious, like open prostatectomy, and I have put like TURP. Now these are efficacious modalities, but there are concerns about morbidity of these modalities. So ultimate goal of any modality today is that it could be, if we could achieve a modality which is safe and efficacious, and let us see whether these modalities fit into those parameters. Now you see, TURP we all know, and I don't have to say anything about it. Here it has a proven efficacy, tried over the last 40 years. Electrocautery is used to resect the prostate. But if we think about the principle of TURP, why TURP came? TURP came as an endoscopic means of achieving what open prostatectomy used to achieve. Because initially it was the open prostatectomy which was gold standard. I am proud to say that we in our audience, there is one urologist who is sitting, and his name is in Guinness Book of World Records, and he has removed 650 gram of prostate by open prostatectomy. Now what I am trying to emphasize, that open prostatectomy was the ultimate achievement. Whenever we think of any treatment for BPH, open prostatectomy gave those kind of results, though there was morbidity. And when TURP was introduced, the purpose was that you should have a modality which could achieve the efficacy that of open prostatectomy. And when we think of efficacy, good resectionist is able to achieve this efficacy, but not that every resectionist is able to achieve the similar results. Now holmium laser enucleation, as I said, the platinum standard. And why I say platinum standard, that lot of randomized control trials today have been published. They have compared holmium enucleation of the prostate not only with TURP, they have compared it with the open prostatectomy, and the results are available to all of us. And initial comparisons were with ablation of the prostate. But even when we do holmium ablations, we find that both the procedures are able to give you equivalent outcomes. The efficacy is available with both. better advantage with the holmium is that your catheterization times are less and the hospital stay is less and no post-operative irrigation required with enucleations of the prostate. Now, when we compare the select randomized controlled trials, we find that the tissue retrieved is much more with holmium enucleations, because howsoever good TURP you may do, with holmium you are able to enucleate at the level of the capsule all around. So tissue removed is, if you look at this slide, the tissue retrieved is much more. These are the comparative kind of prostates, but if you see the TURP, the tissue retrieved is 24 grams, and in HoLEP of the similar size of prostate, you retrieve double the amount of tissue. And these are earlier slides, these are randomized controlled trials, and here if you notice that operation time is more. But as I said, that the way you start doing it and more you do this procedure, you will come to know much less operative time. Today our 90-gram gland can be enucleated safely maybe in 25 to 30 minutes. So that is the beauty of these enucleation procedures, that the time becomes less as the experience grows. And if we look, the efficacy parameters are all almost equivalent as with TURP. So the key points here are that tissue retrieved with HoLEP is significantly greater than that of TURP. Catheter time and hospital stay are significantly less. Improvement in symptom scores and flow rates were not different between the two groups, and we have now long term data which is available, and similarly we have randomized controlled trials, number of them, and these are the representative, one of them I have taken here also, that these are the urodynamically obstructed patients who underwent HoLEP or TURP, and you will find the similar thing, that efficacy is there, tissue retrieved is more with holmium, and the open prostatectomy, the urodynamic assessment is much better with holmium, because you are enucleating completely. This is the randomized trial with the open prostatectomy, and again here we will see this is one trial where 80 patients were done, HoLEP versus open prostatectomy, and you will find that the results show good efficacious results, but the best thing is the hospital stay is less, catheter time is less, and the operation time is less, and no morbidity which is associated with open prostatectomy is seen. Urodynamic outcomes definitely as good as with open prostatectomy. Another randomized controlled trial, and I would say that similar results. So HoLEP patients had significantly less blood loss, catheterization time, hospital stays compared with open prostatectomy. Outcomes were equivalent between the two groups. No transfusions were recorded in HoLEP group compared to 13.3% of open simple prostatectomy group. So the outcomes are as good as open prostatectomy, but the morbidity is significantly less. So now we have a efficacious module which is definitely better than TURP and open prostatectomy, and outcomes are as good as open prostatectomy. Now when we look at TURP, you see the morbidity is there, and the most important thing with TURP, you need an experienced resectionist to achieve this kind of efficacy. The morbidity I would not highlight because it is in the hands of beginners. You can see all kind of complications. We are getting today patients who have had urethral fistulas, you have injuries, bleeding, clot retentions, and even post-operative MIs. So these are the kind of complications which you virtually don't see. People do have hemorrhage, clot retentions and whatnot. Larger the prostate, the complication goes high. So if you see a smaller gland, the TURP, you can get good results, but if you have a higher gland, the morbidity rates increase. So post-operative complication jump, redo TURP rate increases. We are getting large number of cases who had TURP, and today they come to us with recurrent hematuria, recurrent urinary tract infections. They get recurrent symptoms. So if you have a large gland, you will have lot of residual prostates. So this is one thing, and if you do holmium, we have seen you do complete enucleation, so the residual prostate virtually is negligible with holmium. And that brings us that what is this laser prostatectomy that we all want to talk about. We have different kind of lasers, different wavelengths which are available today. The first wavelength which we started with in 1995 was this ND-YAG laser, 1064 nanometers, and this wavelength gave a bad name to lasers. Initially, when we started doing lasers, patients used to have lot of dysuria, lot of slough which kept on coming for a long time post-operatively. Here the video you see, this is the enucleated lobes which are floating inside. These are the two ureteric orifices, and this is the how you can do a complete job, complete enucleation. And these are the kind of lasers which are available: KTP, holmium, thulium, diode. So these are different wavelengths, and the beauty of this wavelength is that it is just like a sharp knife or a precise knife. So when you are doing holmium enucleations, you can work all around, you give a good fossa, tissue is completely removed, and then the question comes that does the quest for a better modality end here? And to answer such a question, we have surveyed all over the country, and the more and more people have started learning this procedure. Today we find that the holmium users, just now I was talking to the Mr. Sumit, who is the national representative here of Luminous in India here, and he said that today we have sold 6400 watt units. So this information is today's information, and every conference I go, the number of holmium lasers which are being bought are increasing day by day, and they are being sold from all corners, from south, west, north, south, east, west. So this is just a wave which has really got generated. Now why we are talking that this is a good procedure? What I want to tell you is that we shell out the adenoma. Like a finger, the fiber moves like a finger in the plane of enucleation, and when we see such kind of fossa, you see this is the viru, and if you see this, how much is the distal tissue to viru, and if we see the sphincter, you will appreciate that the whole prostate gets removed. This is immediate post-op view of this. The prostate lobes are enucleated in their entirety, pushed into the bladder. This is the sphincter here, and they are fragmented and aspirate. And today I am proud to say that size is no limitation. When we are doing holmium enucleations, more than 376 grams of prostate has also been enucleated very, very safely, because bleeding is not the concern. We don't really arrange for blood transfusions. Practically for last 10 years, we have never arranged for blood whenever we are doing even large glands, 100 grams, 150 grams, 200 grams. And the world is witnessing this phenomena. Now what is happening today is that the RCTs which are available, they are practically, you can see that we are able to work today, 3 grams a minute is the enucleation time. As I told you that today 90 gram gland I can enucleate in 25 to 30 minutes. So this is what I have achieved over a period of years of this learning. And morcellation with a luminous morcellator, we can get 10 grams a minute. So the beauty of holmium is the kind of tissue which we retrieve. Nearly 90% of the tissue, up to 90%, say from 70 to 90% tissue is retrieved after enucleation of the prostate. And if you look at the complication profile, you will find that the stricture rate, the incontinence rate, they are very, very low. Only thing is that when you learn, and early in the learning phase, one has to really master. The mentored learning is important, because some people who have started learning on their own, they have created stress incontinence quite a lot. And I must say that the respect to the sphincter, must visualize the sphincter and stay at least 2 millimeter proximal to the sphincter, and that initial incision is the one which can prevent these episodes of stress incontinence. So, it is a part of learning, and I must say that in the last 5 years, if we have compared our data, first 5 years and last 5 years. So, if the incidence of stress incontinence in the first 5 years was 10 to 20%, now it is maybe 3 to 4%. So, the question is that learning is there. So, this is one thing which I am asked at most of the places, that how to do away with this phenomena, because whenever we do open prostatectomy, some degree of incontinence there also we see. The other thing which we have to highlight is the kind of complicated cases one is able to deal with. Earlier, when we were doing this TURP, our anesthetist was refusing some of these cases, 15% ejection fraction, 20% ejection fraction. So when this kind of cases were coming, even now the KTP people come to me and say that the patients who are on anticoagulants, we have done patients on anticoagulants even on continuation of anticoagulants, and the results are good. Not only that, you can have the issues like the bladder stones with prostate, patients on catheter, upper tract damage. We have done patients who have had creatinine of 7, 10. So that is also very, very safe. No problem of secondary hemorrhage or this thing, clot retentions, if you are very, very particular at the time of finishing the procedure. You must inspect the fossa and spend 2 to 3 minutes extra for hemostasis. And this is the thing which you need in upper tract damage. If you have post-TURP symptomatic BPH, this is one area which we are getting more and more now, and this is the group where you are able to enucleate completely. Another area where you are having an advantage, earlier PCNL and TURP we were not doing simultaneously. Now we are doing PCNL and TURP this HoLEP simultaneously because of minimum morbidity of both the procedures. So this is the kind of spectrum we are able to deal with. And not only that, when we talk this holmium, I think Dr. Hemendra will tell you that this holmium is not only a only prostate laser. You can do stones, you can do strictures, you can do PUJ obstructions. So it is a versatile laser too. And this is just some of these post-TURP residual prostates which one want to enucleate completely. I am sure one can do TURP also for them, but the kind of glands which we remove, now I have done 316 glands more than 100 grams. I have done 28 glands more than 200 grams. So this is where it scores over any other modality, because earlier we were just doing one lobe or open prostatectomy for this group of patients. And this is in the earlier phase of our experience, we staged some of the cases. Suppose patient develops a rigor, we would stage it, and that is also very safe. If you do one lobe, after 2 days you can do the other lobe. And similarly, one case I had to convert to open prostatectomy, and this was a case where the patient had septicemia, he was obstructed, his counts were high, he was having some kind of petechiae all over, and had a gland which was more than nearly 200 grams, and therefore, but by grace of God, we have had no mortality. Even in the long term, we have followed most of our cases, and the blood transfusion rate is very low. This is a thing which I must highlight, that 0.01% is the overall transfusion rate for this group of patients. And the beauty is that when you discharge these patients, this is the kind of peak flow which suddenly jumps. I have had patients who were having 8 ml of peak flow, and post-operatively they have peak flow of 54, 64, 70. So this is they say that we are voiding just like a child. So that is because you have enucleated completely. And we collected all our data for last 10 years, and we just sent a questionnaire to our previous patients, contacted them telephonically by post, and now we are proud to say that at Chicago I presented, and we have sent it for publication, this 10-year data, and where you can see this is the pre-operative truss volume and this is the post-operative truss volume. So the truss volumes are sustained. This duration of this enucleation is well sustained. The PSA levels are well sustained. So as long as 10 years. So this is where it scores over any other modality which is available for reduction. And when we think of adverse effects, if we see even holmium has got minimal adverse effect post-operatively compared to TURP, KTP. Of course, ND-YAG is out of question. And need for reoperation, we have had to reoperate 2 cases out of 3,000 cases in last 10 years. One area, as I have been always showing, this actively bleeding prostate. Patient comes, he is bleeding actively, and you think that you do open prostatectomy for a patient like this, And the beauty with holmium is that you go onto the capsule in the beginning. So if you go to the capsule on the beginning, the bleeders are controlled, are taken care of in the beginning, and after that the procedure becomes very, very simplified. And you are always happy once you see that amount of tissue retrieved. The relatives, the family, they all, once they see the amount of tissue retrieved, it is really unparalleled, because the whole tissue has been enucleated. And this is, I was saying, that kind of post-operative results when we see, and the tissue is available for histopathology. It is absolutely no charring, nothing, because it is a mechanical cut by morcellator, and therefore, and this is the actual long-term results. If you see the kind of this patient who had such a big prostate, hardly you have got 12 ml left, 0.48 is the PSA, and the cultures are the patients who have recurrent UTI. We have dealt with various varieties of infected prostates. Sometimes we have done abscesses in 2 stages, but the most important thing is the patients whose cultures were never sterile, they become sterile after the procedure. So summarizing, I presented this in Cape Town in 2006, holmium laser enucleation of the prostate, the platinum standard. Why the platinum standard? Because any size of the prostate can be treated. There are no hemodynamic disturbances, no Trier syndrome, excellent post-operative voiding parameters, no complication especially attributable to laser, and the most important thing is the durable long-term results. So the more we are doing, more we are getting satisfied, convinced, and to our satisfaction, it is the patient who is mostly satisfied. Now we have done lot of questionnaire reviews of these patients, and majority of the patients, I would say up to 96%, they report that they are extremely satisfied after the procedure. So the only thing is, I think we will just summarize now, that these patients who the lasers, they provide comfort. Any kind of laser would give you this kind of a comfort. It is effective. I have already highlighted the urodynamically the patient is more than happy. Not only that, the prostate volume reduction is up to 90%, PSA reduction is significant, and all kind of critical illnesses you can think of, we have done now today, and these are the illnesses which were earlier refused, can be done. It can be done as a day care procedure. If you have a small gland, do it in the morning, you can send him in the evening, and it produces long lasting results. And as I said, that it is versatile, not only in urology, you can do with ENT, gynae, laparoscopy, arthroscopy. So everywhere this holmium is possible, and it is a moderately priced laser. Many a times I am asked this question, that in India how you feel that it is going to go, and I think this is one of the moderately priced laser with extremely low recurring costs, because the fiber is reusable, that is important, and the blade is also reusable for morcellation. Only issue with holmium, which has been, I think, overemphasized, and we presented in Shanghai this thing, that it has been overemphasized in the sense that any procedure you learn, whether you learn TURP, laparoscopy, robotic surgery, there is a learning curve. So if it has a learning curve, why not we accept the learning curve of holmium? And therefore the learning curve is certainly shorter than that of the laparoscopic procedures and TURP. For all urologists who manage to complete the learning curve, HoLEP has doubtless made TURP and open prostatectomy the operations of the past. And I am sure that, I think sometime show this slide, that today Dr. Bansal has really agreed with me that we can offer this procedure, which people say is very expensive. 25,000 is the total price. You see, this is what has been advertised by them for poor patients. So why we are able to do this is because the running costs are negligible. We are just spending 2,000 rupees maximum per patient. So if you don't charge your fees, our hospital doesn't charge its fees, it is economical laser, it can deliver the goods, and therefore friends, holmium laser enucleation of prostate is an effective technique for the treatment of obstructing prostates of any size. The hemostatic capability and versatility of holmium allows multiple urological procedures to be done simultaneously. The safety profile permits it to be done even with severe comorbidities. Available data on long-term results reveal that excellent voiding parameters are well sustained. This is important, and significant reduction in truss volumes and PSA, and the reusability of the fibers make the procedure cost effective and affordable in Indian scenario, and undoubtedly, I have really no doubt, HoLEP is the platinum standard of surgical therapy for BPH. And I think with that I conclude my talk, and I thank you all for patient hearing.